Okay, welcome to the Davies Use Case webinar being presented by St. Stephen's Hospital in Hervey Bay, Australia, on medication administration variance. This is a Davies award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm a manager at HIMSS on the thought leadership team. It's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice, guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes, resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speaker for today's webinar. It is Joanne Hayden, who is the clinical informatics pharmacist. Joanne, welcome to the call, and you can begin your presentation when you're ready, and thank you for joining us today.
Hello, my name is Joanne Hayden, and I'm a clinical informatics pharmacist working for Uniting Care in Queensland, Australia. I've been working in the eHealth team for just over 3 years now, and prior to that, I worked as a clinical pharmacist in our hospitals. Today, I will be taking you through a use case study based on our fully integrated digital hospital, St. Stephen's, located in Hervey Bay, Queensland, Australia. For reference, Hervey Bay is a regional centre located approximately 300 kilometres north of Brisbane in Queensland. I would like to start by respectfully acknowledging the Butchulla traditional owners of the land on which St. Stephen's Hospital is located, and elders past, present and emerging. I also recognise those whose ongoing effort to protect and promote Aboriginal and Torres Strait Islander culture will leave a lasting legacy for future elders and leaders. So let's talk about Uniting Care Health. Who are we? Uniting Care Health is one of the largest not-for-profit private hospital groups in Queensland and is a service group of Uniting Care Queensland, along with Uniting Care Community, Blue Care, and the Australian Regional and Remote Community Services. The hospital group is a major provider of healthcare services in Queensland, which operates more than 1,000 licensed hospital beds and employs over 4,100 people. Uniting Care Health administers the Wesley Hospital and St Andrew's War Memorial Hospital in Brisbane, Buderim Private Hospital on the Sunshine Coast, and St Stephen's Hospital in Hervey Bay. This year, the group of hospitals will admit just under 125,000 Queenslanders and perform more than 88,000 surgical procedures. Here are some of the statistics of our 4 hospitals. You can see that St Stephen's is the baby of the group with 96 beds and 5 operating theatres. St Stephen's is located in the Wide Bay Burnett Healthcare Service region. The Fraser Coast has a population of around 110,000 and is one of Australia's fastest growing regions. The average age is 55 and there is significant health and aged care infrastructure investment. It's known colloquially as the retirement capital of Queensland. The Fraser Coast also has a high unemployment rate of 10% and a high DVA population. This is an overview of the hospital's services, and I think the important points to call out here are our 54 specialist medical and dental VMPs. Remember, we're a private hospital. This means our doctors are not employees of the hospital, but rather are specialists who have their own consultation rooms and use the hospital facilities to treat their patients. We also have around 250 staff at this hospital, and you can see there's a wide range of surgical, medical and day procedures undertaken. A brief history. Before St Stephen's became Australia's first fully integrated digital hospital, it was established in 1905 as St Mary's Hospital in Maryborough, 30 kilometres from Hervey Bay. The hospital was later acquired by St Stephen's Presbyterian Church, and a second day hospital was built in Hervey Bay, the current site of St Stephen's. In 2011, Uniting Care applied for and was approved a $47 million grant from the Australian Government Hospital and Health Fund, which included $21 million specifically for e-health. The new hospital was a greenfield site and purpose-built with medical, surgical, oncology, renal services and a high dependency unit. On the 13th of October 2014, St Stephen's took its first patient, the end of one journey perhaps, but only the beginning of the rest of our story. So this is a quick overview of our system implementation timeline. You can see the journey from October 2014, when the hospital was opened, right up to present day with our HIMSS Davies Award recognition. Down the bottom, I've included some of our leadership changes during this time. You can see that even with a number of changes, we have achieved some pretty spectacular results at St Stephen's. And this brings us up to my case study today, medication administration variance. Specifically, I'll be talking about how we decreased errors in medication administration with the implementation of a closed-loop electronic medication management, or CLEM. So what's the local problem? It's well recognised that the administration of medications is a potential area for adverse events in patient care. We use pre-implementation workflow data and literature reviews to identify clinical problems that the IT solutions could improve upon. And here are our targeted areas that we thought could be improved with a closed-loop electronic medication management model. So we're looking at adverse drug events, medication omissions, high alert medication errors, transcription errors, prescription of drugs where there is a documented allergy and related near misses, and duplication of therapy. So the case study focuses on reducing medication omissions. And by omissions, I'm talking about when an ordered medication is not given with no valid clinical reason. Omission or overdose of medication at the administration stage is the most frequent type of medication incident reported. So our baseline data showed that 2.41% of medication errors were found to be due to omissions. And a review of the literature revealed that 0.73% of medication administrations cause an adverse drug event. Now this might not sound like a big number, but when you consider that almost 1 in 100 times that we give a medication to our patient may result in patient harm, then this becomes something we want to improve. So what was the solution? We decided to create a closed-loop electronic medication management system. We implemented barcoded medication administration, or BCMA, along with computerized physician order entry, or CPOE. With the barcode scanning functionality ensures the right drug and dose is given to the right patient via the correct route. In addition, the clinical decision support rules provide a further mechanism for validation at the point of administration. We developed custom reports to accurately show ward, patient and medication scanning rates for the individual clinicians. This gives us detailed oversight of the medication administration documentation, such as the reasons for omissions. Initial reports showed that the BCMA rates were lower than expected, and so a time in motion study was conducted to try to elucidate reasons for the low scanning rates. A pharmacist was engaged to observe clinical nurses during their usual workflow and record their observations. We did notice a Hawthorne effect, where people will perform better when someone is watching them, but even so, we're able to identify some reasons for the workarounds that the nurses were using. Using the custom reports, along with the study, allowed us to identify workarounds and reasons for scanning errors, which could then be investigated by the eHealth team. So here's a nice pictorial of our closed-loop medication process. And if we start at the top, on admission, we take the patient's medication history. This is reconciled with what is going to be continued as an inpatient, along with any additional inpatient orders. Here at St Stephen's, we're using profiled automatic drug cabinets, or ADCs, along with unit dose packaging to store and retrieve our medications. Moving along to the barcoded medication administration at the bedside, and finally, when the patient is ready for discharge, another medication reconciliation is completed to determine ongoing care. All this information is then available for the next admission history. So CLEM closes the gap in the medication cycle, reduces medication errors caused by poor documentation or communication, and ensures the patient receives the exact medication which the doctor prescribed. The build and design of our system was clinically driven but technology supported. So that is, rather than the technology dictating what can be achieved clinically, we wanted our clinicians to design what they wanted and then implement the technology to support them. The integration between our systems was crucial to the improvement of medication safety practices. All these systems must be able to talk to each other in order for the closed loop to exist. I've included a workflow diagram here of how we're using our health information technology to support our doctors' prescribing workflow. And a screenshot here of one of our clinical decision support alerts that fire to the doctors during prescribing. This one is highlighting that a duplicate therapy has been proposed for order. And here I just wanted to highlight the governance tools that were used for the implementation and for ongoing build and design decisions. So first we look at our vision and why this change is important and how do we want our future to look. Then we look at our guiding principles. How will difficult decisions be made? This is where we use clinician engagement with reporting through structured committees to make the difficult decisions. And finally, the benefits. How will we measure our success? What do we need to implement to achieve our targeted benefits? This diagram gives you an idea of the clinician and end user engagement in the governance and decision making. You can see that we have the eHealth team in the middle directing and managing this process. So clinician adoption, how do we engage our end users in this process? Hospital and group leadership play an important role in encouraging our clinicians to have a voice in design and build decisions. They do this through regular personal communication to our clinicians. Clinicians, and specifically doctors, were closely involved in governance committees. We demonstrated the benefits to clinicians with reports, time savings, and improvements to patient safety, and we demonstrate the ease of use and alignment with their workflows. And of course, the availability of technical support on-site, over the phone, and remote screen sharing to assist with troubleshooting and workflow questions. As an example of how we maintain our clinician engagement, I wanted to share some of our CPOE data that we used to drive our CPOE results just prior to our HIMSS Stage 7 accreditation last year. You can see here there's a significant jump from Quarter 2 to Quarter 3 in 2018. During this time, our executives were passing along reports at first monthly and then weekly, individually to our clinicians of their CPOE results. Along with individualised results, de-identified data was emailed to all clinicians to generate an atmosphere of friendly competition. We were able to identify individuals who required extra support and also understand barriers and opportunities for learning. The feedback came back loud and clear from our clinicians that there must be an error in the system as their results were much lower than what they were expecting. When the eHealth team investigated, we found there were some background routing issues for our no cosign required orders. Once this was corrected, we noticed a significant increase in our CPOE figures. This really demonstrates just how engaged our clinicians are with their system, that they could recognise problems with reporting data based on their own workflows. Moving on to the BCMA design factors. So things that were taken into account when designing the health IT were which barcode system would be used for the coding, for example, linear, matrix, etc. The type of identification band that would be worn by the patient. And in fact, our eHealth team tested a number of patient wristbands to ensure they would withstand the rigours of use. They wore them 24 hours a day for a month, yes, even on weekends and to the shops, just to ensure that the ink would not wear off and the bands would remain intact. Also, the placement of the barcodes. In the end, we needed to have two different types of barcodes on the patient wristband to facilitate scanning by different systems. The placement of these barcodes is important to ensure accurate scanning. If they're too close together, the scanner may not be able to read the barcode. Also, the type of scanner that's used. Would it be wireless? Where would it be located? Remember, we're a greenfield site, so these kinds of decisions could be incorporated into the design of the rooms. In the end, it was decided to put scanners beside the bed as well as on the workstation on wheels to facilitate scanning at the bedside. For example, at night, you might not want to wheel the noisy workstation into the patient's room. You can just use the scanner in the room for medication administration. Another design factor was the infrastructure to support the technology, such as the Wi-Fi coverage throughout the hospital to ensure there were no dead spots for connectivity. And finally, the unit dose packaging and how this was undertaken. So I thought it would be helpful to discuss what is unit dose packaging, and I'm aware that not everyone would understand what I mean by this. So it's the repackaging of medications into single unit packages. You can see from the pictures here, we take a full box of tablets and pack each individual tablet into its own sachet or unit dose. We do the same for amps, vials, syringes, etc. The barcode on the package uniquely identifies the medication, and as far as I know, we're still the only hospital in Australia who are unit dose packaging on site. We're really hoping for others to come on board with their closed loop meds so we can put some collective pressure on our wholesalers and get them to do the unit dose packaging for us. So here are some of the machines in pharmacy that do this work. You can't tell from the photos, but they're big and bulky and they take up a lot of space. A pharmacy had to undergo the rigorous application process for a manufacturing license in order to perform this work. And finally, onto the practical considerations. Of course, if you're repackaging every medication, then each one is going to require double the shelf space in pharmacy. So you can see I've got a photo of the full box on the left there, and then each tablet in its sachet to the right. So this is something that needs to be considered when designing pharmacy shelves and space requirements. Okay, so here at St Stephen's, we use profiled automatic drug cabinets. This means that the orders flow from the electronic medical record to the drug cabinet. This allows our nurses to remove medication specific to their patient and the time that the medication is due. This improves medication safety and reduces medication selection and administration errors. So what are our BCMA rates? For our reporting, we calculate the rates of positive patient and positive medication scanning. So we're checking that the nurse is scanning the correct patient as well as the correct medication. And I just want to point out that this is a little different to the HIMSS stage 6 and 7 requirements, which require reporting on BCMA attempts only, not necessarily correct scans. I've included a few years of data here just to show the dramatic improvements we've had in our BCMA rates, and we were able to use our custom reporting to improve these rates. So with the reporting, we get increased visibility over what is actually occurring in real time. We can see if the patient and the medication barcode was scanned, and we can also see exactly what number or code they were scanning. This helps with investigating errors. I've included some pictures of what the nurses are actually scanning for visual reference. So that's a patient wristband on the left, and you can see there are two different kinds of barcodes on there. There is also a couple of pictures of the unit dose sachets and just a snip from the report that we look at. You can see the level of data that we're getting. So the issues identified from these reports. Firstly, we can see if they are scanning the incorrect barcode. This is obviously a user or workflow error and not a build problem. One error that came up was that we had an issue with the calibration of our barcode scanners. So if the caps lock key was depressed on the keyboard, the barcodes would not be recognised. This was an easy win for us with a quick recalibration of the scanners. It was also noted that the two different barcodes on the patient wristband were causing some confusion. Since we couldn't remove or change them, it was a training point for the nurses to ensure they know which type of barcode to scan at the bedside. We also teach them to put their finger over the incorrect code so the scanner does not pick it up when it's held at a bit of a distance. It was also reported that the scanners were losing charge or not charging. This was a bit more of a mystery, but was solved when it was noted that there's a small piece of plastic that is designed to hold the scanner in place when the cradle is attached to the wall. Since our cradles are flat on the workstations, this piece of plastic was preventing the scanner from sitting neatly in the cradle. A quick switch around of the plastic switch and suddenly our scanners were able to charge effectively. The report shows attempts as well as positive scans, so as mentioned, we can see exactly what code or number they are scanning. and scrambled reads. So if the packaging of the sachet is a little scrunched, the barcode cannot be read correctly. Again, this is a training point. We're teaching them to keep the sachet flat with an opaque surface behind it to give the best scanning results. So now I want to dive into how we're actually utilising the health IT in clinical workflows, looking at the electronic medical record, CPOE, BCMA, and our technology focused on safety and improved medication processes. So here's our closed loop again. We're going to look at how we use health IT in each step of this process. Medication history. So the pharmacist documents the medications that the patient was taking prior to admission. We know that an accurate medication history is vital to improving patient safety. We then move on to medication reconciliation. This is where our clinicians decide what medications will continue while in hospital and also if any additional medication orders need to be placed. The CPOE has some smarts behind the scenes which guide the ordering process, and you can refer back to the workflow slide for details of these. We use the electronic product formulary, which in a private hospital does not have any limits. Our clinicians are able to prescribe any medications they want. We do not have a limited formulary in the traditional sense. So if a drug is not yet built into the system, they can alert the eHealth team and we will build it in for them. The medication order catalogue and medication order sentences ensure that orders are placed safely and efficiently. And of course, any details can be changed as required prior to signing. The build considerations here ensure that we maximise conversion rates through reconciliation, and I will explain that, and that we maximise auto product assignment rates to aid profiling at the ADCs. So conversion is simply where the order is converted from the medication history to an inpatient order or from an inpatient to a discharge order. Automatic conversion means that the prescriber does not have to make another selection decision at this point. Auto product assignment is where a particular drug item is assigned to that order for removal at the ADC and also for scanning at the bedside. So now we're at the bottom circle, profiled ADCs and unit doses. So the auto product assignment, as I mentioned, will assign a product to the order based on built-in variables. When the pharmacist verifies the order, checking appropriateness of use and ordering, they are able to change the product assigned if necessary, or assign a new product if one is not already there. Just to look at our technology-enabled pharmacist screens, this is the pharmacy multi-patient task list, where they see referrals and new prescriptions, etc. And the unverified orders monitor, or UVOM, where they see new orders that have been placed that need to be verified. And around to BCMA at the bedside. Our technology-enabled nurses use Care Compass to track their patients and activities. They can see priorities and other information from here. And we utilise the Medication Administration Wizard, or MORE, for medication administration. This shows a 2-hour adjustable window of medications due to be administered. Here, the nurses can scan and document the administration. So they scan the patient wristband, scan the medication, and finally administer the medication. And moving along to discharge medication reconciliation. The clinicians determine which medications will continue on discharge, utilising the auto conversion smarts again to guide selection and prepare a discharge summary for the patient. All this information is then ready for the next time the patient may be admitted to hospital to ensure an accurate medication history. So this is an overview of the pharmacy interfaces that we have at St Stephen's Hospital, and I must point out that these were the interfaces at Go Live. We've had a slight change since then. We've outsourced our pharmacy services to a third party and are now sending information to the pharmacy software via a VPN tunnel. But essentially it's operating the same way. So you can see there's a two-way interface between the electronic medical record and the ADCs, which are run by Omnicell, and the messages are then sent from Omnicell to the pharmacy software, which then interfaces to the wholesaler, Medicare for PBS claiming, and the billing software. So the benefits of the closed loop from a pharmacy perspective. We've got time saved with automatic restocks. So daily reports back to the pharmacy from the ADCs of exactly what is required to be restocked. No more waiting on handwritten requisitions. We've got security with fingerprint access so we can see exactly who is doing what in the system. And traceability with easily generated discrepancy reports. And again, we have visibility of exactly who is accessing which drugs. We have expiry tracking, so we have less shrinkage. We can move stock with a short expiry to higher use areas to eliminate wastage. And we have flexible stock control with PARs and reorder levels. We can change the minimum and maximum levels as needed depending on usage, so we can reduce cost and wastage. We've no running out of impress stock because of the auto restocks, and the on-call pharmacists with remote access, so they can log in from home, see all the orders, log into the ADC, see what stock is available, and may be able to prevent a trip into the hospital out of hours. Now let's look at the reporting again. So reporting in a digital environment is both easier in the sense that the EMR means you have transparency and facts, but we now have so much information we're in danger of losing sight of what we're actually after in our data tsunami. Nevertheless, this reporting means that we can use data in a meaningful way to improve patient safety and workplace efficiencies. So we're deriving value from our health IT with patient safety and quality results. We have reliable data, which means we can investigate errors immediately, and we can help to prevent medication errors with the clinical decision support, rules, alerts, etc. These are a few examples of near misses that were prevented with the closed-loop electronic med system. You can see I've highlighted the warfarin near miss here. So warfarin was scanned at the bedside but was not ordered for that patient, a near miss that was prevented with the use of the BCMA technology. And going back to omissions. So what is an omission? As I said right back at the beginning, we're classifying an omission as a medication task that was documented as not done or not given without a valid reason. When we look at these reports, the reasons, or lack of them, are investigated and clinically evaluated against agreed criteria to determine if it is a valid omission, for example, the patient may have been asleep, or an invalid omission, for example, the medication task was missed. We're reporting on any omissions classified as invalid, and you can see the data here. The graph does fluctuate, and this represents new staff and changes in ward management and highlights a need for increased training and support. Now, I think this slide is pretty exciting. There are some amazing benefits that we have been able to measure documented here. If we focus on the graph on the left, you can see this is the number of impressed lines in each clinical area. This is referring to the number of unique medications that are kept in the ward medication room that are available to staff without requiring a requisition to pharmacy. So here we're comparing data from our paper-based hospital to St Stephen's. And you can see there is almost double the number of medications available on Impressed. This is in part due to space saving. By unit dose packaging, we are able to provide the exact number of tablets, amps, syringes that are required without wasting space with bulky boxes and packaging. Alongside this, you can see there's a dramatic decrease in the Impress stock value. So there's more medications available, but with less money spent. Again, because we unit dose package, we can provide only the number of units that are required and charge accordingly. And this is another exciting slide with some of our documented benefits. These figures were taken from a benefits realisation piece that was done a couple of years ago, but I've put some of the more recent data in those earlier slides. There's an opportunity here to look at measuring these benefits again. One misconception is that a digital solution will result in less work for the humans, but this is not true for our technology-enabled pharmacists. You can see here that they still undertake all the same activities as their paper-based colleagues, but then we add in a few more unique to the digital environment. What we found, though, is that the time saved in some of the former activities is then utilised in completing the new activities. And here are some of our lessons learnt. So I've discussed the change in traditional workflows for pharmacy. There's a longer onboarding and orientation process as staff are learning a whole new way of working. And we find that new graduates coming straight out of uni are picking up the new workflows faster, but that everyone gets there in the end. Then we needed new skills in the pharmacy department with all the machines and maintenance. Barcode maintenance is an ongoing process as new drugs and brands are released onto the market. And the increased stock levels in pharmacy with additional shelf space required for unit dose packaging as well as the bulk stock. Our pharmacists need to learn a new way of processing the digital medication data for the pharmaceutical benefits claiming from the government. And there's always tension between budget and efficiency. I've discussed the workload of unit dose packaging. This is a time-consuming process, and we're hoping that more sites come on board and we can put some pressure on the wholesalers to do this for us. And the initial slow uptake of the scanning workflow has been ameliorated, as I discussed, with fixing the identified problems. And finally, there are the frustrations at the ADCs with the time taken to remove medications and also jams that occur due to overstocking. So implementation and challenges. We encourage ownership of results with the wards and their nurse unit managers. They're given detailed reports right down to the individual scanning rates, and we foster an atmosphere of friendly competition between the wards. Positive reinforcement through the awarding of coffee vouchers is also used to motivate staff. The individualised data also lets us target training and support those who need it. Another challenge that we have is to encourage real-time reporting of scanning failures, which allow the eHealth team to be agile in investigating problems and implementing changes where required. For example, some of the build changes that we implemented from these reports were to build in the barcodes for the IV fluids so that these could also be scanned. We now also build in the manufacturer barcodes so that if an item cannot be unit dose packaged, then the outer box or packaging can be scanned to ensure the closed loop. We also recognise that regular in-services from the pharmacy, eHealth and nurse leadership is important. So we're continually optimising and improving our systems. We recognise the need for a clinical informaticist to be on site for face-to-face communication. It's important to identify and then support super users who can support others in their teams. We have regular reporting to the hospital executive and leadership, continual doctor training and support to maintain their CPOE results, and vitally, we need to continually encourage all our users to log problems rather than use workarounds so that we can improve the system for them. So just a little lighthearted look at patient safety, taken a little too far perhaps, with a tattooed barcode on the back of this lovely gentleman. And in summary, so the local problem, we wanted to decrease variance in the medication process with device integration, closed-loop electronic medication management, and unit dose medication cabinets. The implementation of a barcode medication administration process, or BCMA, helped to decrease adverse drug events, which are often the leading cause of harm to hospitalised patients. St Stephen's leadership tasked the teams with developing a clinically driven, technology-supported medication safety process. And healthcare IT, a key factor and workflow change was the implementation of the computerized practitioner order entry. In the CPOE workflow, errors are intercepted at the time of order with the clinical decision support. The integration between the CPOE, pharmacy systems, the medication administration record, barcode system, and the medication dispensing cabinets was crucial to success. The improved workflows in moving from the paper environment to the digital environment enabled St Stephen's to reduce the variance in their medication process. With an increase in CPOE adoption and the utilisation of BCMA, St Stephen's has realised significant decrease in adverse drug events and medication omissions. And this is just some of the literature I've referred to with the statistics in the first couple of slides. Thank you for your time and listening to my case study.
Well, thank you, Joanne, for sharing your Davies stories with us today. And let me remind our listeners where to go find other Davies use cases and information on how to apply for Davies. That information can be found at the Davies website at HIMSS.org/Davies. That is HIMSS.org/Davies. Again, I'd like to thank you for listening and have a good day.